instead of going through them one by one, what I would like to do really is to go through what I think are the important things that we have conclusions that we've drawn to, and perhaps explain to you not just the conclusion, but how we've come to these conclusions. Let's talk about ultrasound guided procedures first. This really is what prompted the USIG to be asked to write the guidelines, and it certainly is probably the area of most concern to people in the POCUS world. The Spalding criteria clearly require the use of high-level disinfection when the blood vasculature is in close proximity to the probe. So that really is what Spalding has required. Now, ASUM has taken a slightly different approach to this, and their recommendations are that low-level or high-level are acceptable following use of ultrasound-guided vascular access, provided the transducer is deemed to have remained at some distance from potential contamination. Now, this was a compromise made in response to concerns largely from emergency physicians about the practicality and the costs of performing high-level disinfection in ED departments following the very common use of vascular access. And they correctly point out that there is no evidence of clear benefit or harm in the distinction with the use of low-level or high-level disinfection, particularly given the standard use of sterile probe covers. Our recommendations are different. USIG actually is pushing much stronger and is strongly recommending high-level disinfection over low-level disinfection following vascular access use. And there were three reasons why we've come to this conclusion. First of all, at the end of the day, there are sharp needles being used, and the protection that is offered by sterile probe covers, in and of themselves, they don't guarantee that they will not perforate, and particularly in the context of needles being used in an emergency setting. So no matter what way you cut it, there is a risk of contamination that cannot be avoided. We feel that the idea of this term of some distance really is way too ambiguous, and for clinicians to be making in the middle of a busy medical procedure. But perhaps the most important point that I'd like to stress is there is very little difference in terms of cost and practicality between high-level and low-level disinfection, and certainly not enough to warrant the non-use of high-level disinfection, if at all possible, following vascular insertion. Next thing I'd like to talk about is the probe and the machine. The 2017 guidelines really specifically refer to probe-only reprocessing or disinfection, and this is because they are reusable medical devices. The rest of the machine is not a reusable medical device and really falls outside the Spalding criteria. But from an infection point of view, this makes absolutely no sense. It's self-evident that the machine can act as a surface for pathogen transmission, and it needs to be disinfected. And so what we've done in terms of providing guidance is we've really pragmatically made a decision to separate high frequency and low frequency areas of touch that warrant disinfection from low frequency areas. And our recommendations are as follows: that the high frequency areas, which are self-evident, it's the keyboard, the screen, the probe holder, etc., they need to be cleaned to the same level of disinfection and with the same frequency as that of the probe. Low frequency areas, such as the rest of the machine, they do need to be cleaned on a regular basis. Now, what about cost and practicality? Well, we've seen what's available already before, but when we think about cost, I think there are three components that need to be considered: capital expenditure, consumables, and maintenance costs. And all three need to be added up and considered. When you're deciding what to use for your department, you really need to consider these three components. But rather than worry about it, I think the best way of approaching cost and practicality is to actually define what they are, and then make your decision as to whether you find this burdensome or not. Two things to say. One, options exist, for high and low level disinfection, both with and without capital expenditure. I fully appreciate how difficult it is to get capital expenditure, but options exist where capital expenditure is not necessary. Second point to make is we went and looked at the costs of what was available in Australia. Now, these are sort of combined costs that really, take on board capital costs, consumables, and maintenance, and also consider the costs not just of cleaning the probe, but of cleaning the machine, the probe, and the high frequency areas of the machine as a total. And the costs really were, from my point of view, I thought surprisingly low, between $2 and $5 for low level disinfection and $3 to $23 for high level disinfection. Similarly, in terms of practicality, the times needed for high and low level disinfection really ranged from very short 2 minutes to 3 minutes, and with a maximum of 30 minutes. The consequence really, and the conclusion that the USIG have drawn from this is that time and cost are not plausible barriers for the adoption of appropriate infection control mechanisms. These costs in absolute terms are not high, and relative to the cost of secondary infection, the costs of potential litigation, they are very, very small. And we really argue strongly that that certainly within the Australian context and our ability to fund medicine, that these are not particularly burdensome. What about the use of sterile probe covers? Well, firstly, the use of handmade covers, the use of Tegaderm strips, they were never designed for this, and they provide an ineffective barrier and should never be used. Sterile probe covers aren't actually medical devices and are not covered under TGA legislation, so there's no clear definition of what they are. There is good research to show that dedicated probe covers made for the purpose have a very low, not a no, leak rate, and they also minimize the image degradation that they cause. And so our recommendation is that only high quality dedicated probe covers should be used. Now, when should they be used? Well, USIG has recommended, we've just really remained consistent with standards and mandatory standards in some cases, that probe covers should be used when in critical procedures such as vascular device insertion. Now, I know this differs from some other international guidelines, and there is room for debate here. We did not recommend absolutely mandating them for transesophageal use, but we do recommend their use. The point being that, I suppose, one, there's not a strong tradition of use within Australia, and certainly some toe probes are left in place for quite some time, and there is quite a bit of image degradation, so we do recognize that. I think the point about sterile probe covers is that, yes, I take the point from, let's say, the Intensive Care Society in the United Kingdom, which recommends but doesn't mandate them, that if you perform a high-level disinfection on a probe and can maintain that degree of disinfection until its use, then there is, little advantage in the addition of a probe cover. I think there are two arguments against that. One, it's very difficult to maintain that level of disinfection, and that usually involves the use of a sterile plastic bag anyway. Secondly, the sterile probe cover does offer a sterile as opposed to a disinfected surface. It provides some protection for your probe, and it also minimizes the soiling of the probe, so that makes cleaning and then subsequent disinfection more effective. So really on that basis, and to remain consistent really with current standards and I suppose current practice within Australia, we've gone with recommending that they be used in all situations, in all cases. Ultrasound gel. Now this is actually an area with quite a bit and a strong evidence base behind it. There are several well-documented case series of infection directly attributable to infected ultrasound gel. There are two things that you need to know about, you have to achieve when using gel. One, the gel needs to be sterile, and two, the packaging needs to be sterile as well. And on this basis, we're recommending the use of sterile gel single sachets in all cases. It is implausible that the bottle of ultrasound can maintain a clean surface throughout its lifespan within intensive care. Yes, it's feasible. It's possible, but it's impractical to do this, and we recommend against their use in all situations. Documentation is important. I think it's important that we will be judged on our paperwork as much as our practice, but notwithstanding that, documentation following high-level disinfection is a standard across all disinfection and sterility procedures for reusable medical devices. It's an area of difficulty because what's required is details of not just date and time, but who did the test, who performed the disinfection, the probe that was used, and also cycle times for various products depending on or procedures depending on what are used. Unfortunately, the documentation systems again have been developed really with an eye on the traditional users of ultrasound. With dedicated technicians, they work fine, but in the context of ICU, they do not work very well. And I think absolute compliance is going to be a struggle for many of us. Again, I would ask and urge manufacturers to try and come up with a system of documentation that would work better for intensive care workflows. Documentation following LOD is not mandated, but it is preferable. And finally, I think what I think is the most important issue and the biggest barrier to good infection control is the tasking of doctors to clean probes. To me, it just makes no sense that the only piece of medical equipment we're asked to disinfect and clean is ultrasound. It's a recipe for failure. And I think it's an artifact of the historical piecemeal funding that has developed for point-of-care ultrasound. Now, clearly, doctors do have a role to play in infection control, but they share that responsibility with hospital organizations. So both doctors and or hospital administration have responsibilities, but those responsibilities are different. And I think it is highly incorrect and wrong that physicians are asked to consider prioritizing patient care against ultrasound disinfection tasks. And what USIG has come up with is that cleaning and disinfection should be the responsibility of adequately trained non-medical staff. I suspect this will be our most controversial recommendation. Doctors can be reasonably expected to assist with cleaning, subject to their ability and clinical demands, but we place full responsibility on hospital administration to provide equipment and resources, including human resources, for proper infection control. It is unreasonable that patients are exposed to unclean equipment because there is a lack of trained staff or staff with adequate time. What about COVID-19? We just really made some brief comments. I mean, I think point-of-care ultrasound has come into its own in its ability to assess without moving the patient, the respiratory and cardiovascular state. And almost all COVID patients admitted to intensive care will have been the beneficiaries of ultrasound medicine. And the two aspects of intensive care that we can provide to COVID patients, really, the basis of our management is supportive care and impeccable infection control. We did consult widely and got some expert infectious disease and microbiology opinion and confirmed that low-level disinfection is adequate for all suspected or proven cases of COVID-19. And so really, I want to sort of draw to a conclusion, really what are the recommendations that we came to? So we started with some general principles. So first of all, we acknowledge that ultrasound medicine is now an integral part of our ICU care. We recognize that clinicians and organizations both have responsibilities to minimize infection transmission. Doctors, if they're using ultrasound equipment, need to be familiar with the equipment, and that includes the infection control policies related to that. And we also recognize that there is a lack of research and a need for research to improve infection control. Specifically, our recommendations are as follows: the use of single sachet sterile gel only, the use of high quality sterile probes during invasive procedures, cleaning as a mandatory first step preceding all disinfection processes. In terms of choosing the level of disinfection between high or low level, we've really gone with the ASUM ACIPC guidelines with a few small exceptions as follows. That it's important to clean the machine as well as the probe, that high-level disinfection should be used over low-level disinfection following ultrasound-guided procedures. And we are consistent with the ASUM guidelines with mandating that documentation is necessary after high-level and preferable after low-level disinfection. And finally, probably the most important recommendation is that dedicated trained staff, non-medical staff, should be tasked with performance of ultrasound disinfection. We did produce a chart to assist with what you need to do in various situations. And really that concludes my talk. I think ultrasound medicine has added greatly to the care of ICU patients, but we need to minimize the risks associated with them.